Good morning. Can everyone hear me okay? Great. See a lot of familiar faces, see some new faces. I'm Leanne Bailey Clayton. I'm the Director of Health Services and the Licensed Nursing Home Administrator here at the Forest at Duke. I've been here for 26 years and have had a couple of roles, assistant administrator, social worker. So these guys, they're my heart. So we're going to spend some time in talking about the transition series. This is the transition series, the first of 4. And we are going to be sharing with you and talking about what it means to be in a CCRC, what is it that your contract you have signed up for, and what in fact the roles are of the professionals here that assist you with that. So we do have 2 social workers, Carissa Campbell, Jennifer King. Jennifer covers the alphabet A through K based on your last name. Carissa covers L through Z, also based on your last name. If you're a couple with 2 different last names, then they decide how that works out. Usually it's based on whoever raises their hand for needs first. That's normally how that goes. So we are happy that they are here with us, and they will tell you a little bit about themselves as we move through this conversation. So I also want to introduce Jessica Hackett. She is our resident navigator, and specifically what a resident navigator is what you may have heard in other communities as someone, admissions coordinator, director of admissions, that type of thing. It's relative to identifying what your needs are. If you are in the hospital, if you've had an acute change here at the Forest, and what that means to get the ball rolling, if you will. It's not a clinical word. So that she is navigating the necessary paperwork that must arrive before you do to our nursing staff, and to make sure, in fact, that if you're in the hospital, that you are actively being followed by the Forest at Duke and that advocate for you to return to the Forest to the appropriate level of care. If, for instance, you are going to have an elective surgery, you would either be in touch with your social worker or with Jessica, so we could talk in advance about what that looks like. If it's an acute situation, we go into action. We follow you in our physicians' rosters in my chart to see if someone's gone to the emergency room. We, of course, know if someone's gone to the emergency room, and so we follow you in that way. Jessica is our point person for discussing with the case managers and anyone in the hospital about what your care needs may be here. The circumstances may certainly present itself that Jessica's in touch with you or your family member as well if you were there for an acute reason, and make sure coordination of care is going as it needs to. Just a little housekeeping, we will field questions at the end, and we will not field questions related to specific residents or specific cases. If we need to talk about that offline, we certainly will do that, okay? The social workers, what don't they do is a better question. They very much are about resourcing in the community for you. You're living here in a continuing care retirement community. A continuing care retirement community is much different than a standalone assisted living or nursing care facility, because most often folks move into independent living and they enjoy all the amenities that are offered at the Forest and other communities of this nature. But many people have told me over my 26 years that the reason they move to a CCRC is for health care. So one of the large part of things that we do is make sure that you're having the health care that you need. And please don't immediately think that means the health center. There's much health care that happens at the Forest at Duke, including the clinic as well as the Forest at Home, that can happen in your independent living areas. We are a 90 capacity health center, and I think you guys are like, what, 400 and something strong now at this point. So it's very important that we do utilization utilization of care for space in the health center, as well as folks getting support from the Forest at Home or another agency that the social workers will speak about in terms of in our community what can be resourced as well. So they advocate for they get to know your family. It's about continuity of care. So it's very important. So Embry's, I'm going to use y'all as my examples, okay? So it's very important that Jennifer is, getting to know the Embry's, and she is having an opportunity to know them when they're well, so to speak, okay? Because knowing who their support system is, knowing who their children are, knowing that, they've moved all their doctors from, outer Mongolia to Durham, all those things that happen when people move to a community. And then Jennifer is in a situation that, let's say, Stuart hurt something and needs to come to the health center. She knows how to jump right in and support them. Now, there's only 2 of them at this point. We are working toward having a third person that will be working with them. And so I expect that we will see some results from that relatively soon. And we want to make sure that the resources that we have available for you are certainly available as you need to. We have many experts on our staff who can field questions for you, but much of that work happens with these 3 professionals. So let's talk about the type of CCRC we are. I don't want to insult anyone's intelligence. There are people here that know far more detail about some of this than I do, but I'm going to tell you the part that matters today, okay? We are a Type B contract, and that means that we are a rental community. What you pay in your monthly service fee, you are renting your physical space. But what does that mean in terms of your service here and transition at the Forest? So to tell you that, it's easier to tell you what we are not. So take the Cedars of Chapel Hill, for instance. They're a really good example. They are a different type contract. They are a real estate mortgage contract, but they allow people to age in place. They have a full-blown home care. You can have 2 home care aides with you 24 hours a day if that's what you need. You're paying for it, but that's what they have. They started out with 38 healthcare beds. It is not their model for people to move through the continuum. It is their model for people to age in place, okay? They have since added, I think, 38 more, but that is not our model. Our model is a continuum that expects people to move through the continuum, okay? I don't want to steal Jessica's thunder, but I am going to steal this thunder that I promise you we are not trying to determine how it's best for just any old person at the Forest to go to the health center and live. We don't have the space for that type of thing. We have a very effective and efficient way to do bed utilization for people's needs as they need it, an actuarial that has worked out for us for 33 years. Are we 33 years old now? For 33 years, and we will continue to work that way. So just know we're not coming to find you under the cover of darkness at night at 3 in the morning go, I know, I told you. So we will, that's not what we're doing. We are working closely with residents and their families to make sure you're in the right level of care at the Forest at Do. I do want to add that the Forest at Home is not a level of care at the Forest, okay? It is not a level of care. It is support. It's support. And the most important thing is there is a guideline that if you are requiring 4 hours of personal care assistance, more than that a day, then we need to work with you about what your level of care is at the Forest. If you need somebody to go to the grocery store, if you need somebody, am I doing somebody else's stuff already? Oh, okay. I might have done somebody something. Okay. If, in fact, you need somebody to go to the grocery store for you, or take you to the doctor, or whatever the case, but there's no need to mark a tally on your refrigerator that says, oh, I had 3.5 hours of somebody helping me with grocery store and cleaning up my house extra. They're going to come get me. That's not how it works, okay? If you have physician-ordered services that are needed for you in terms of monitoring or safety. It's all about safety. So just know that that's how that works. But the levels of care here are independent living, skilled nursing, assisted living, and memory care. Okay? Is that all of me?
Good morning, everyone. My name is Jennifer King, and I am one of the social workers here at the Forest. I look around and see a lot of familiar faces and a lot of residents that I am very thankful to work with every day. I have been here for almost 4 years. March will be 4 years that I joined the team. So I'm going to go over a little bit more about home care services because Leanne stole a little bit of my thunder, but I'm going to use my lightning to come back. As Leanne said, residents can have up to 4 hours of care in their home, and that's focused on personal care, so hands-on care, such as having a nurse's aide to help give a bath, get dressed, make sure someone's taking their medicines, helping them to the bathroom, those types of things. There are specific expectations for those 4 hours. If someone is on hospice services and they would like to stay in their cottage or their apartment and they would require 24-hour care, we do allow that so that if someone chose to stay in their home setting at the end part of their life and they're on hospice services, they could have more than the 4 hours of home care services. Social workers do have an approved list of home care providers. So yes, we do have the Forest at Home. But there are other agencies in the area that residents may want to use. Maybe they have a pre-existing relationship with that group and they would like to go ahead and use them. We also provide residents with that information so that they can look at choices. They may, a lot of home care agencies require certain number of hours. A lot of them, it's 4 hours if they're outside of the forest. Our home care is a little bit more flexible because they're licensed in here to serve our residents. If someone wants to use a private provider, like a single person to come and help them in their home, that is fine, but there is a checklist of items that we have to have before that person steps foot on our campus to provide care. Things like drug tests, criminal background, those types of things. And if people are interested, we have the checklist and we can send it to them so that they can look at it and make their choice in terms of what they, who they might want to work with. Acute and safety interventions. One of the things that Chris and I always say to people is, unless it's an emergency, it should not be a surprise if you have to come to the health center to stay. Saying that, the times where someone may have a fall, they don't need hospitalization, but they need to come to the health center for rehabilitation or just for a temporary stay, utilizing the 15 prepaid days that you have in your contract or in your agreement. But if there is a safety issue that is a concern, we may have to come and assist the resident and help them come to the health center. Other than those emergency situations, we talk with residents. That's one of our goals, is to get to know residents. Now, can we get to know everybody all at once? No, that's not gonna happen. Can we visit everybody every year? No, we're not going to be able to get everybody every year. We have to sometimes triage situations. And we also have to rely on residents knowing who we are, that they may want to reach out to us. We have a lot of residents that we have met who know us, but maybe we haven't necessarily sat down with them every year and talked about how things are going. But we do know our residents, and we have other staff members who share information, which is really helpful. It's one thing that we do during orientation with our new staff members to let them know the importance of their involvement. If they see things going on with the resident that is concerning and different, they are encouraged to report it. It could be an acute issue that's being resolved, or it could be something that's ongoing that may need our attention. So we rely on our village, on our campus, to help us to know when people may have needs. Next slide, please, Jess. Thank you. So as Leanne said, our health center is licensed with 32 assisted living beds, which include our 10 memory care beds. So we have 9 households and 5 stories. So our first floor household is specifically for memory care, for residents who may have a form of dementia, form of cognitive impairment, that if they were walking around alone without supervision, may end up in a dangerous situation. That program is more focused on doing in-house activities and those types of things to keep residents engaged. And then our second floor, for all of you who may be visiting, is assisted living. So every household on the second floor is assisted living. And then we do have 2 beds in one of our skilled nursing areas that are licensed for assisted living. So you might say, why would you do such a thing? Well, if one spouse needs skilled nursing and the other spouse needs assisted living, it's very nice to be able to have your loved one close by and still get the services that each of you require. And included with our 58 skilled beds, we have 4 Medicare certified beds. So those, we have Hickory South, or 3 South as we call it, has 10 private rooms, private bathrooms. That particular household is specific for our independent living residents. Whether residents come from the hospital and require a Medicare or Medicare Advantage stay, or if they need to come for a temporary stay in one of our temporary rooms to feel better after a stomach virus, or I have the flu and I can't manage in my apartment right now, or I have the flu and my spouse doesn't, but I care for my spouse and I'm just not able to do it for this time period. So there are options. You have 15 prepaid days, and so it depends on how you want to spend those. We do have Medicare, we do take Medicare A in those beds, and we also do work with Medicare Advantage plans. All right, I'm gonna pass this on to Carissa. Carissa Van Zyl.
Okay, good morning. So I'm Carissa Van Zyl, formerly Carissa Campbell. We're still working on getting that changed everywhere. So there's only one Carissa that I know of on campus. So it's me if you see different last names in an email or something. So I've been here for 4 years in December. Previously was in a similar CCRC, have experience in a freestanding, mainly Medicaid facility, so I'm definitely thankful for the hazing I had for the last few years before I ended up here. So, crystal ball here. I picked this up from a rehab director that I worked with at my last facility of nobody has a crystal ball. So in theory, when everyone moves into the forest, we've had doctors do evaluations, we've had an actuary or someone who looks at different diagnoses to figure out, oh, Jennifer's probably going to be alive for 8 more years. Or probably more than that. But that only goes so far. I always think of the movie The Notebook, which came out a while back, but there was a quote in there where one of the characters said, you know, medicine only goes so far, and then there's God. So we could look at things and we just never know what may come up. So for residents that come in, we think they'll be okay for a while. Some things may come up. I've had residents say, gosh, since I moved in, I feel like I've been playing a game of whack-a-mole. Things just keep coming up, and that's okay. That's what Jennifer and I are here for. You know, we've had residents who come over to the health center. They, you know, with the team, make the decision to move over permanently, and then a couple years down the road, they're able to move back to independent living, which is great. There's no, you know, one game of life like the board game that residents go through here, so we kind of just have to meet the residents where they're at to make sure that their needs are met. So with that said, every decision is made on a case-by-case basis. So we don't have a cookie-cutter formula of, oh, Jessica's fallen 3 times this year. She's been to the emergency room twice. I've had 2 security officers call me with concerns about her. It's time to move. That's not quite how it works. Everything is a case-by-case basis. And that can depend on, local support in the area, a resident's willingness to have services come in. Jennifer outlined, that we have home care. Some residents are fine with someone coming into their apartment up to 4 hours a day. Others will say, I don't really like having someone in my space. I think it's time for me to move to the health center so I can still keep that feeling of independence. So when the decision is made, like Jennifer and Leanne referenced to, you're a part of that team. So as best we can, it should never be a surprise of, oop, Jessica, it's time for you to move to the health center. We would have had conversations. We would have had, different interventions put into place. Of we've tried home care. We've tried physical therapy. We've tried your daughter coming to manage her medications. We're still not being successful, so we need to look at a level of care change. But we do have a health maintenance committee that meets weekly, and that is comprised of Leanne, who is our chairperson, our medical director, clinical nurse manager, therapy, social worker, and the director of nursing. So we talk both about our current independent living residents who are in the health center, how they're progressing, what their goals are, where we try to have a crystal ball, but we don't, where we see them ending up. And then we also talk about our residents who may have some concerns that are going on in the community, whether that be, I think it may be time to work together with Jennifer's family to talk about her graduating from driving and what can social work do to provide resources after, say, Dr. Little has that initial conversation about it not being safe anymore. And then, of course, we like to have resident participation and then family participation as well. And that's one of the beauties of this model of we get to know you when you first move in to independent living at the Forest. So that way, when something acute happens or it's time to have these hard conversations about a level of care change, then, we're not strangers. We kind of know who each other are.
Hello. So I'm Jessica Hackett. Actually, my 8th anniversary at the Forest was just last week, so I've been here a long time, seen a lot of stuff. And more than half of my life I have spent in healthcare, specifically geriatrics. So I'm starting to head that geriatric way myself. So that being said, we're going to talk about some of the myths that go around this campus. And I kid you not when I tell you some of these, okay? There has been myths that we go kidnap people from their homes in the middle of the night, on a golf cart no less, okay? And bring you over to the health center because, various things went wrong or were just mean. And we decided it was time for you to move. That is not true. I don't know how else to tell anybody that. We don't just go into people's homes and just take you, okay? Like Carissa said, there are conversations that lead up to moves. Now, the information that gets shared throughout this campus, it's kind of like a high school, not gonna lie, all kinds of gossip on this campus. I mean, things that I have heard and that are absolutely false throughout the years it's very comical, I have to tell you. So, and one of those is that we get kickbacks and commission for the people that, how many, especially me, that I get kickbacks and commission for how many people I admit to the health center. If that was true, I wouldn't be working here anymore because I'd probably be so rich. So I'm just telling you, you can check my bank account. That's not how that works here. Absolutely not. The other one is the Forest needs my apartment. Oh my Lord. Our waiting list is so long. We don't need anybody's apartment. We don't need your apartment. We don't need your cottage. We don't need any of it. So we're not trying to move you because somebody needs your apartment. I promise. And the other thing I really want to try to hit home here is we're here to do a job. There's going to come a time where you may or may not. How many of you have read your contract, just out of curiosity? Okay. Did you read the part in there that the forest does have the right to move you to a higher level of care if it's deemed necessary by the health maintenance? Okay. Do your children know that? Okay. Because a lot of them don't. And this, you did this wonderful thing for them and you moved into the forest. You made this choice, this wonderful choice, this gift to them so they didn't have to make the choice for you. But you didn't share the piece with them that this is the kind of community where we do have that right to do that, okay? So I need you to understand there's a lot of brilliant people in this room, have had highfalutin jobs, stuff that I'll never, ever understand in my life. But what we do understand is cognitive problems, physical disabilities, and the fact that people need a higher level of care sometimes. You could sit in front of me and tell me that you're the Attorney General of the United States, and I would look at you and, you can't tell me to do this, I'm not gonna do it. Well, I don't really care. I don't care who you are, who you were at that point, okay? You need help. Unfortunately, our brains fail us sometimes, and you need that support. And us as a team are gonna try to help make the best decision that we can with your input, with your family's input. This isn't just made in a vacuum. These decisions are not made in a vacuum. It's very well thought out, okay? And I know sometimes that, one day you'll see somebody in the cafe and the next day they're gone and they're swept over into the health center. I promise you that person had an incident of some sort, whether it was at the hospital and they had to come for a short visit or, and sometimes, I'm just gonna be real honest, people that you think are alert and oriented all the time aren't. You may see them that way because they can present really well for a short period of time. But underneath it all, when it comes down to it and their daily tasks and living every minute to every hour, they're struggling. So we see a lot of things that you all don't, and I just want to hit that point home. That leads me to, there's 3 sides to every story, not 2. There's what you think, there's what others think, and then there's what we know, what the staff who's going through this with these residents and their families absolutely know is the truth. So when you hear a rumor, I just ask that you take a moment, pause, and before you get in an uproar and say, oh my God, how can they do this to this person? There's a reason. Just know that, just like if it's you, we're not gonna make a decision for you, ever, unless we absolutely have to, unless there's no other recourse. And that very rarely happens, very, very rarely, okay? I've been here 8 years. I think there's been maybe 2 or 3 instances that I can think of that we absolutely had to make a decision that went south. But it was in our right. It was in our right to do that. May not have agreed with it, but it was in our right. So I just ask that you have the patience and trust us. Because I don't have very much room in the health center right now, so I would prefer that y'all stay healthy. So that's what we're aiming to do, okay? I will get to you in 1 second. Pardon? I'm the resident navigator in the health center. So Leanne had said that basically it's the admissions process into the health center, but I've worn a lot of hats throughout the year, through the years that I've been here. Backup social worker on multiple occasions, through different social workers I've been here. I also back up the clinic. I play a lot of different roles and wear a lot of different hats over there. Okay, and we'll leave the questions here with Leanne.
So we will take questions at this time. You're going to bring the mic down. If you'll wait for the mic, that'd be great. Thank
Not
you.
jumping off the stage. Testing. Testing. Okay.
Hi, if a person does not have family and you're putting together this team to determine whether a person should move, is it ever permissible to have some sort of an independent outside person be part of that decision?
So, everyone heard the question?
It's not on our team, but outside person.
Everyone heard that question? So when you come to the Forest at Duke, there are several things that you're responsible for making us aware of. You're responsible for making us aware of who your healthcare power of attorney is. You're responsible for making us aware of who your power of attorney is, and in what order you would like family, if they don't happen to be those people, contacted. So there are people that, in fact, employ geriatric care managers over a period of time. Those people are not part of the decision. Those people, of course, can be there with you in terms of sharing information, helping you remember the details of what was in the conversation and be supportive about that. But typically, that specifically has to be someone that you've designated in advance of a crisis or a need for a move. Another question? Yes, ma'am.
Hello? Okay, so if I'm not mistaken, hospice could be a long time.
So we work with 3 hospice providers, 2 primary providers being Duke Hospice as well as Transitions Hospice out of Raleigh. We do have a contract with Liberty, but they've, I think, been on our campus one time in all these years. But the point is that the physician certifies hospice. They have to do that. Is it every 3 months they have to recertify? Okay, it starts with 3. You have to be certified for 6-month life expectancy to start with, and then it's 3 months after that. Continuously. So if that person is being certified for hospice care doesn't mean you're going to only live 6 months or less. It doesn't mean that. What it means is that physician's best projection, you have a life expectancy of 6 months. Yes, it can continue for a much longer period of time. But as long as that physician is certifying that, we will stand by that. As Jennifer explained, if you are under hospice care and your situation is safe for you to have someone in your home, then you can either have family members rotate in and out of your home during that time, or you may hire someone privately to care for you during that time. And we will continue to assess that that is a safe situation and that that's being able to be managed in such a way that you're getting the care you need. Other questions? Yes, ma'am. She's coming.
I think I know the answer to this, but I figured I should get it from you.
Yes, ma'am.
We have 15 prepaid days in the health center. What happens if you use 5 days? Is it every year you get 15 days?
Okay, so the question is, what is the nature of your prepaid days once you use some of those? How are they accumulated after you've used those? So the prepaid days are, if you are in the health center for 3 days in November, for every month you are out of the health center after your discharge, you get 1 day back up to 15 maximum. Other questions? Many of you have into these series, so you probably know all these answers. Okay, well, thank you so much for your time and attention. There will be 3 additional pieces to the series. One involves the providers, one involves marketing with us, and what's the 4th one? I don't remember the 4th one. Oh, dementia. Yeah, living with dementia in a CCRC. Okay, I couldn't remember it. That's the joke, right? Okay, thank you so much for your time and attention.